Hello, this is Dr. Kim Jeongil. Today, let's look at what kind of research the existing scholars have done on occlusal plane control. There are many orthodontists, but not that many have studied the occlusal plane. There are Dr. Schudy, Professor Kim who made MEAW, and Professor Sato. First, Dr. Schudy said that the occlusal plane inclination is closely related to orthodontic treatment. So he measured the functional occlusal plane. This is the angle between the mandibular plane and the line, connecting the distabucal cusp of mandibular first molar and the cusps of the mandibular first premolar. And this angle was called the OM angle, that is, the occlusomandibular angle. This patient is 26 degrees, this patient is 11 degrees. Dr. Schudy said that the normal value of the OM angle is between 10 to 11 degrees and 21 to 22 degrees, and if it is greater than 21 to 22 degrees, it is a high average OM angle, and if it is less than 10 degrees, it is a low average OM angle. Dr. Schudy said that in the case of high average OM angle, the following should be noted. Tooth movement in which the posterior portion of the occlusal plane rises upward is not desirable. In addition, tooth movement in which the front part of the mandibular plane rotates backward and downward, based on the SN, is not desirable. Therefore, when the SN to mandibular plane is more than 45 degrees and the OM angle is more than 25 degrees, it is not recommended to use class 2 elastics. If the posterior growth was sufficient, it would be possible, but otherwise, this kind of force vector was not desirable. It is desirable to retract the maxillary anterior teeth by using a headgear. In addition, it can be an open bite at the end of the treatment. It is said that a posterior bite block type, acrylic splint that covers the occlusal surface of the mandibular second molar is worn. Anterior vertical elastics are applied to the anterior part, and a high pull headgear is used. For severe class 2 malocclusion, only the maxillary premolar can be extracted. In the case of class 2 open bite, one of the mistakes we can make is that the mandibular anterior teeth move the teeth too lingually. Dr. Schudy said the low OM angle, that is, the low angle case we are talking about. In this case, the treatment to extrude the mandibular posterior teeth is desirable, and it is also desirable to use a class 2 elastics. He said that intrusion of the mandibular incisors should be avoided if possible, and that the upper incisors should be able to intrude, and if possible, it is better to treat with non-extraction. Dr. Schudy said that in the case of low OM angle, the root of the mandibular anterior teeth may move to the lingual side during leveling. Therefore, it is desirable to apply labial root torque to the mandibular anterior teeth by using class 3 elastics together. The goal of general treatment is to fit the average, but not for low OM angle cases. Let's look at this like Björk's paper. High angle type, open bite, that is, Dr. Schudy is called high OM angle. At this time, the eruption direction of the mandibular anterior teeth was said to be further extruded. On the other hand, in the case of the low angle type, deep bite, that is, the low OM angle, it is said that the mandibular posterior teeth are further extruded. This type of tooth movement is called high angle and low angle type dentoalveolar compensation. In other words, in the study of Dr. Schudy and Björk, the larger the OM angle is, the larger the OM angle is. The larger OM angle means that the lower posterior teeth are intruded, and the mandibular anterior teeth are extruded. It is said that the lower the OM angle is, the smaller the OM angle is. The smaller OM angle indicates the mandibular posterior teeth should be extruded. Professor Kim, who made MEIW, spoke about the occlusal plane. Professor Kim measured the Downs occlusal plane and used the bisected occlusal plane. The bisected occlusal plane is the line connecting the overlapping midpoint of the maxillary and mandibular anterior teeth to the contact area of the distabecal cusps of the first molars. It was said that the anterior limit of the occlusal plane should be located 1.5 mm below the lip line. In general, 3 mm is normal for one to lip line. The normal overbite is also 3 mm. Therefore, the midpoint of the maxillary and mandibular anterior teeth is 1.5 mm, which is the middle stage. It also said that the posterior part should be perpendicular to the AB plane. Prof. Kim's treatment strategy is that the AB to BOP is 90 degrees. In the case of Class 2, this angle becomes smaller, and in Class 3, this angle increases. What is the treatment strategy for Class 3 malocclusion? The AB to BOP of Class 3 malocclusion is greater than 90 degrees. BOP is flat and the upper jaw is located posteriorly or the mandible is located anteriorly. To make this 90 degrees, point A must move forward, or point B must move backward and downward. That is, the maxillary protraction or the chin-cup therapy will move the maxilla forward, and the mandible posteriorly and downward. Or you can change the BOP. In other words, it induces intrusion of the mandibular posterior teeth and extrusion of the mandibular anterior teeth. This can be achieved by using Class 3 elastics. However, there is a limit to intrude the mandibular posterior teeth. The AB to BOP of Class 2 malocclusion is less than 90 degrees. To make this 90 degrees, point A located in the front must move slightly backward, and point B located in the rear must move forward. Therefore, it is necessary to induce the maxillary backward and mandibular forward movement. Another method is to extrude the posterior part of the mandible and intrude the maxillary posterior teeth to set the occlusal plane to 90 degrees. At this time, the upper anterior teeth are extruded. This can be achieved mainly through a Class 2 rubber band. Professor Kim used MEIW to use Class 2 rubber bands a lot to obtain such a therapeutic force. The following is what Professor Sato studied about the occlusal plane. This is a study on the importance of posterior occlusal plane. The posterior occlusal plane is the line connecting the distabecal cusp of maxillary second molar and the cusp tip of maxillary second premolar. Would the upper POP be good when determining the POP? Or is it better to set the POP of the mandible? Let's think about it together. In Class 2 malocclusion, both maxillary and mandibular POPs are steep. Steep POP needs to be adjusted by rotating counterclockwise. What if you want to control the maxillary POP at this time? In order to flatten the steep maxillary POP, the upper molars should be extruded, and the upper premolars should be slightly intruded. Even in MEIW, various complex adjustments are required in order to get it. Also, What reaction might occur when the maxillary molars are extruded? Since the mandible moves forward, it is good for Class 2 treatment. However, in some cases the mandible may go posteriorly. Class 2 malocclusion may worsen when the mandible moves backward. Professor Sato suggested various steps to intrude the maxillary posterior teeth at first, in the case of Class 2 high angle, and then extrude them. On the other hand, even in Class 2 low angle, the force system was recommended to intrude the maxillary posterior teeth at first and then extrude them. However, I measure the mandible POP when treating Class 2 malocclusion. What will happen if you measure the POP of the mandible? In order to change the mandible's steep POP into a flat POP, the mandibular molars become intrude and uprighted. The premolar region is extruded and root mesial movement occurs. This can be easily achieved through MEIW with tip-back activation. Flattening the steep mandibular POP makes the mandible easier to move forward. If the mandible moves forward, it is very effective in treating Class 2 malocclusion. In addition, a space between the upper and lower molars is created, and the upper molar becomes passively extruded. If the mandibular posterior teeth are insufficiently uprighted, that is, if steep POP remains, the maxillary incisors will be extruded and treatment will be completed. However, if the mandibular posterior teeth are sufficiently uprighted, the upper incisors will have a more aesthetic appearance. Flat POP is one of the characteristics of Class 3 malocclusion. This flat POP needs to be made into steep POP for Class 3 treatment. If maxillary POP is measured, it should be steepened. The maxillary molars become intruded and uprighted, and the maxillary premolar teeth should be extruded. This can be achieved through MEIW with tip-back activation. Professor Sato said that the MEIW with tip-back activation was used at Class 3 high angle. And in the end, it should be adjusted like this. In addition, even in Class 3 low angle, tip-back activation is applied to intrude the maxillary posterior teeth at first, and at the end, they are asked to adjust to flat. I measure the mandibular POP and make it. At this point, the mandibular molars will be extruded and the crown will be moved to the mesial. This can be achieved through some adjustment of MEIW, that is called curve of MEIW. So far, Dr. Schudy, Professor Kim, and Professor Sato have discussed the occlusal plane in malocclusion and its control. Thank you for watching.